All right. So, because a couple folks are going to be out, I am recording this lecture. And so, much of the first few slides we've already hit this morning. So, we're going to kind of skip through those and we're going to go on down to the general impression of your patient. So, we're going to kind of get into this. So, when you're looking, and we're talking primarily from trauma, but again, patient assessment is patient assessment, regardless of what the patient's problem is. And again, they don't come neatly packaged in trauma or cardiology or medical emergencies. Usually there's a conglomeration of three of them. Look at your patient and look and see what your first impression is of this. Now, let me ask you a question. When we say first impression, realistically, all y'all are EMTs. Some of you are working almost full time as far as hours and everything. So, what do we mean by first impression?
What you think of the patient after walking in the door?
Okay, so what information are you going to get from that? I see hands all over the place. This is awesome.
If they're conscious or not, if they're forward breathing, if they're talking, stuff like that.
Perfect, very good. John, we'll work our way forward.
Just a basic idea how bad they are, what might be the problem. Like if someone's in a tripod position and starting to breathe, not a good impression.
Mm-mm.
No,
not at all. Not at all. Claire? Okay. Did you have your hand up?
I didn't have my hand up, but
Okay. Did you have your hand up?
Yeah, I was just going to say based on appearance mostly, and kind of a combination of what dispatch tells you as well. You don't want to base everything on that, but it gives you a clue.
Absolutely. So you bring up the whole concept of dispatch, and this is really important. On the way here, okay, expert tip here. When y'all take your national registry exam in just a few short months, you're going to have questions. You're going to have a scenario, and I'm going to be giving you some questions like this. But you're going to have a question on the dispatch phase of the call. So I'm glad you brought that up. So it's kind of like, okay, what do you do from the time you're dispatched up until the time you make contact with your patient? And so we'll delve into that a little bit deeper, okay? Here, and then back over here.
I was going to say the same thing about dispatching the first few things you hear about the call, but also kind of whenever you enter that door and before you even blink for the first time, that's kind of like if someone walked past the hall and they saw you like this versus just sitting at the chair you're in.
Yeah, very good, very good. And again, keep in mind, dispatch only relays the information that they're getting from the general public, and the general public is notoriously unreliable as far as things that are happening. I think Landon was telling me about a call you all ran that was supposed to be a cardiac arrest with CPR in progress, and you got there and the patient's in rigor mortis and nobody's doing CPR. Okay, and so just kind of be really, really fluid with any information you get from dispatch, as well as information that you find on the scene through your assessment. Okay, here and then back here.
I forgot.
Okay.
What about the previous interactions with the patient who's been there multiple times?
Okay. Excellent. Mark?
mechanism of injury and index of suspicion.
Good. And that's all part of this first impression. Now, here's the key thing that you need to do next. Look beyond the obvious. Okay? You see a guy standing here holding his chest, you automatically begin to think what?
Dr. Young's having a heart attack.
Could be, but what if I open my hand and there's blood under it? Ooh, maybe Dr. Young's been shot in the chest by an irate student who wasn't happy with his or her grade, whatever. Anyway, so look beyond the obvious and take in not only what you see on the patient, take in everything in the surroundings. This is critically important when we're talking about trauma, especially with automobile trauma, in the fact that you got to look at the outside, you got to look at the inside of the car. Don't be distracted by massive damage to the outside of the car. Cars today are designed to look that way. Why? Because it's better for the car to absorb the energy than the occupant inside. So they crumple. Literally, they crumple. However, once you get to the inside of the car, now that's kind of a different thing. You look, is the steering wheel, is it broken? Is it bent? Okay, do I see blood on the steering wheel? What about the windshield? Okay, is the windshield broken? All right. Uh, are there things in the car that could have become missiles? What about other patients in the car? Could the other patients in the car have become projectiles, or in a T-bone type of accident? You know, the energy is going this way. Perhaps the other person was coming this way at the time the driver was going this way, and now they both have coup contra coup type of head injuries. And so that's the kind of the thing that you're going to look for. Look for mechanism of injury. Don't spend a ton of time focused in on mechanism. Just make a note of it as you're going through. Again, as we talked about earlier this morning, the skin and your patient's posture here can give you a ton of information. I think as John said a while ago, if you come in here and I'm sitting over like this, that's not a good first impression, is it? At least for me, it's not, because that tells you that I'm in trouble, okay? This tells you a lot as well. If I'm lying on the floor and I can't get up, that tells you a lot as far as how I'm positioned and how the patient reacts or Catherine does not react to your approach. Okay. So as soon as you get in there, and you should take into consideration how much bleeding that the patient's doing, as well as their breathing patterns, their pulse, and all of that information that you see both on the patient and surrounding the patient. Once you make contact with the patient, introduce yourself. And I'll leave it up to you how you introduce yourself. You can say, hi, my name is Bill. I'm a paramedic, or I'm paramedic Young. But the next thing you should do is get the patient's name and then begin using it. Little hint for you, okay? When we start doing simulations and scenarios in here, and then especially next semester, one thing I'm going to expect you to do, doesn't matter how good you are technically with a simulation, because some of these will be graded. If you do not get and use the patient's name when it's available within 60 seconds, you fail the simulation. Why? We like to hear our name. We like other people to use our name. It says, I am important to you if you're going to use my name. So using the thing of, hey, bud, or hey, guy, or things like that, you're not fooling anybody. They know you're not really interested in me because you don't even take the time to listen to me telling you what my name is. Next question will be to ask your patient, what happened? Many times, medics will ask the question, well, why did you call us here today? I don't like that. It's not wrong, but I don't like that because if you're not careful, it comes off as, why did you interrupt me today with your problem? Okay. So I like the thing of, well, tell me what happened. You may be able to do that and not have a problem. I won't penalize you for doing that, but just kind of understand that some people may react negatively to that. Richard.
I was going to ask, so would something along the lines instead of, so what was it that made it bad enough that you felt the need to call 911? Would that be better, or do you think?
It depends. So it depends. Number one, you got to practice on how to talk to people in different situations. For the most part, you and I talk really informal. I'm not big on titles when you guys get to this level. So if you call me Bill, I'm perfectly okay with that. If you've noticed, a lot of the emails that I've sent out to you, I sign off as Bill and not Dr. Young. Don't typically do that with the first year students because I want them to kind of get an idea. When I go out and I'm dealing with other paramedics, I never use Dr. Young. It's always just plain Bill. So it's all in how you deliver that and how the question. So yes, that could give you a lot of information, especially if the patient says, I've been having this problem for 2 days. Okay, so now an important piece of information would be, okay, and again, you got to practice talking to people. Again, you would have to figure out, okay, what made it worse now that it was important that you called 911. And each one of us has a different delivery method. One of the things I just simply like to do is just ask, hey, can you tell me what happened? Okay, tell me what happened. And going on from that, then I can say, okay, so tell me, how did it get worse today? And so I just kind of leave off that made you call 911. Because sometimes for me, I've heard other medics do this, it comes across again as, why did you bother me? All right. And so each one of you develop your own. This helps to develop and to identify the patient's mental status, and as well as if they got an open airway. This is all from your general impression. So if the patient's talking to you, it tells you two things. Number one, they're awake. Number two, they've got an open and patent airway. That's all it tells you. It doesn't tell you if their breathing is adequate or not yet as far as where we're going.
So with instead of like asking how it changed today, could you, like, let's say the problem's been there for a week, could you ask them like how it's, not necessarily use the word like evolved, but how it's changed over the
Oh, absolutely, yeah. And not using the word evolved, unless you're like talking to one of the science teachers over on the other side of the campus. Again, use the language that your patient is going to understand. Don't talk down to your patients, but again, let me give you an example. Again, I don't care for y'all calling me Bill. Okay, I actually like it. Number two, I don't use Dr. Young with other paramedics. When I go do site visits, accreditation site visits, like the one that I did Monday, Tuesday, and the president of the college is sitting there and the dean of the college is sitting there, I always introduce myself as Dr. Bill Young. Why? Because that's the level that they are on. And then when they leave, we go back to just simply using Bill. So you're exactly right. Use the language your patient is going to understand. And that's key to getting information. So once you've done this, now you're going to go on to your initial assessment, your primary survey, whatever you want to call it. We're going to go down that ABCD list and get the information, okay? Kind of a review from this morning. Don't get distracted. Bill's number one rule is, everybody, treat what's going to kill them first. Treat what's going to kill them first, okay? Now, try to get the social history of the patient when it's appropriate, because many times it can lead into information as to the why of what's going on right now. If you have an older patient and they have dementia and things are going on in that area, if you find out, they really don't have anybody other than the patient's elderly wife to take care of them, now that gives you some information that's really, really important, that you may need to call social services, not to come down on them, but to get help for both the patient and his wife. And so that information can be helpful. So what you're going to do is, again, just like we talked about this morning. I told you were going to hear me talk about assessment until you're sick of it, okay? Work in a logical manner and do your assessment with a few changes the same way every single time. All right? So what do I mean by that? Well, you should do your initial assessment, Thomas, do your general impression, get your ABCs done. Then you're going to move on in trauma to do your rapid head to toe. Okay? And you need to do that the same way every single time. Except, like a call that I ran one Christmas Eve when I worked down in Georgia. Car traveling wrong way on the interstate, drunk driver, Christmas Eve, crashed into another person, to a couple in a pickup truck. Strangely enough, it was the fire chief from down in Whitley County, one of the fire departments down there, and his wife. And the dash dropped down on her abdomen. I had no access to her lower extremities. You'll hear me tell this story again because we'll illustrate it. I'll use it to illustrate when we talk about abdominal injuries. But there's no way I could assess her lower extremities because I couldn't get to them. Okay, so again, you may have to change this up. You got a guy who's got his arm trapped in a tufting machine at Dalton who's doing carpet. You're not going to be able to assess PMS on that arm. You can't get to it until you get it extricated. However, 99% of your patients you will be able to do free access and do your assessment the same way every time. That way it minimizes the possibility that you're going to miss something. Two things that you're always going to be looking for. One, airway issue. Okay, that will kill your patient really, really fast. Number two, exsanguinating hemorrhage. Exsanguinating is just a really, really big, important word for bleeds like a stuck hog. Okay, they are bleeding profusely and they are going to die. You have to stop it. You have to put tourniquet on if it's an extremity, or if it's someplace else, you better start packing with gauze, which we will practice. Packing with gauze is not as easy as it sounds once your fingers in your gloves get wet with blood. Putting a tourniquet on, also not as easy as it sounds when your gloves are wet with blood. But we'll try to do that as much as we possibly can. So once you're in this, and again, one of the nice things is if you get to work with a partner and you work with that person on a consistent basis, it almost becomes like telepathy or ESP. Okay, one person is automatically anticipating what the other person is going to need. And you both don't have to be paramedics for this to happen. So the longer you work together, it's kind of like when Austin comes in and he's doing his assessment and all of a sudden he realizes, man, I'm going to have to start an IV on this guy. Well, his EMT partner has already got the IV set up and established. And if you got a really good partner, he or she already knows, oh, we're going to need at least an 18 and preferably a 16 IV catheter and have those out ready to go. And so that's one of the nice things about working with a partner all the time. So as we're looking at this is, and you will hear several different types of primary assessment. For all means and purposes, they're all going to be pretty much the same, okay? This one is X, A, B, C, D, E, okay? We transitioned from, much like as you'll learn in ACLS, every 5 years, ACLS comes out with new guidelines. I think it's so that American Heart can sell new books, but I'm a little jaded on that. But they bring up new information to come out with this. And so your primary assessment has also evolved a little bit. And this is a pretty good one of where X is exsanguination. You're looking for obvious bleeding as you're coming in. ABC, airway, breathing, circulation. D is going to be disability, any type of major fracture that you would have to come in and address. And then you come down to E, environment. You want to keep them dry. You want to protect from hypothermia. And you want to keep your trauma patients warm. Don't care how hot it is outside. You got to keep your patients warm. And you'll hear this again almost as much, if not more so, than patient assessment. Put your patient in the back, your trauma patient, put a blanket on them, kick the heat up in the back of the truck. Okay, now we don't want them to sweat, all right, but we want them warm. Richard.
So I know this is mostly going to fall under the X, but would something like amputation also follow under disability as well?
That would fall under X because of the amount of bleeding. Now, Here's the thing. If you have a really clean amputation where it is literally sliced off and not torn off, you may have little or no bleeding. One of the things that the arteries do when you have a clean cut, okay, is that they will constrict and pull back into the extremity, and they'll close themselves off. So you may have some seeping. But again, if you've got an amputation, regardless of how little bleeding is there, you better put a tourniquet on because you don't know what's going to happen when you begin administering fluid. And you guys are going to learn how to administer blood in here as well, okay? And so that's a very, very good question.
So I'm gonna give you a scenario someone gave me.
Okay.
A very unlikely scenario to begin with, but like they were talking about like an iron factory or something where there's hot metal around, and like a piece of metal went across someone's arm and it's clean cut, but because of the heat,
Cauterizes.
it cauterized it. Would
Yeah.
you still put a tourniquet on?
Absolutely.
For that? Okay.
Absolutely, because you don't know what's going to happen. It's easier to control bleeding when it is already controlled than to try to control bleeding when it has resumed. So absolutely, if you've got an amputation or a tearing or even a severe avulsion where part of the arm is torn off, put the tourniquet on there to help control bleeding. Mark.
So just as far as tests and stuff, is this saying that if you had like a question where it's like the patient is bleeding excessively and their airway is obstructed, you deal with the bleeding then the airway?
You would deal with what's going to kill them first. So it depends on the scenario, okay? So if you got a patient that's got bleeding from the lower leg and an airway problem, you're probably going to go with the airway, okay? But if you've got a patient that's bleeding from a femoral artery and an airway, chances are you would address the bleeding from the artery with one person, your partner, and then you would immediately go in and deal with the airway. One of the things that I will try to not do for you with a few certain with a few certain exclusions. On a written exam, I'm not going to put you in a Kobayashi Maru type of situation, okay? So I'm not going to put you in, it's kind of like no matter what answer I put, it's going to be wrong. Now, we get out and we're doing scenarios, and we're doing them for the learning part, not for the grading part. Oh, I'll put you in a Kobayashi Maru all day long because this is what you can expect to see on your patients.
What is the registry looking for in that? Because I was just talking to one of my medics about it, and they said in PHTLS and for the registry questions, it's always bleeding first.
You're going to treat what's going to kill your patient first. So here's the reason I can tell you that with confidence is that I, for the last several years, and I continue to do so, I work with the registry to help develop their questions. So you're going to be put in a position, and again, I'm not going to give you a situation, registry won't either, of saying, oh, you got a patient that has his leg sliced off and he's not breathing. What are you going to do first? That's not a realistic situation. But what they might do would be put you into a position of saying you have a patient with a compound femur fracture that is oozing blood and the patient has an occluded airway. What are you going to do first? Or you should first. Now, obviously, in that situation, you're going to go with the airway, okay? If the bleeding is what's going to kill your patient first, then that's what you're going to do. Guys, I want you to understand something about medicine. Medicine is as gray as Catherine's shirt. There is no black or white. There is no black or white. Now, you may have heard a lot of urban legends about the registry exam. If you have, come and see me for the truth, okay? But the registry exam really is looking to test your knowledge in the real world, okay? Again, they're not going to give you a question that no matter what you answer is going to be wrong, okay? So there will be no-win situations in that, I can promise you. It'll be challenging. It will be challenging, okay? But you got to keep that in mind, all right?
For primary assessment, would you prefer us to memorize the X, A, B, C, D, E, or March, or does it matter?
Doesn't matter to me. Does not matter to me as long as your assessment is done in a logical, organized manner of where you're dealing with the most important things and you're coming down to the lesser important things. I'm okay with it.
I just didn't know if you'd have like a question on a test or.
I will not tell you, I will not give you a question that says, In X, A, B, C, D, what does the E stand for?
Okay.
Won't do it.
Well, I didn't know if you, like, on a test, what's the primary assessment, and then if we put down March instead of X, A, B, C, D, E. Okay.
Nope, won't do it. Won't do it. All right, so let's talk about different types of bleeding. Capillary bleeding is literally what that is. The top layer of skin has been gone, and you have an oozing of bleeding that's going across below the dermal layer. Now, we've got a ton of capillaries that are beneath the skin. So when the skin is removed, the capillaries will begin to ooze and come out. Now, capillary bleeding is not that big a deal, or oh my goodness, this could be a big deal. So, for example, it's not life-threatening as far as the bleeding itself goes. It could be very life-threatening because of infection, especially if you're dealing with an older person, okay? Or if you're dealing with somebody, I think we were talking earlier in this class today about somebody goes out on a motorcycle, no helmet, t-shirt, shorts, and flip-flops, and they lay the bike down, and now 80% of their body is road rash. Now we're running into a problem where it could potentially become a hypovolemic shock type of thing, and an issue of infection. Oh, by the way, and I digress just a little bit. Anybody read the report of a lady in Australia that they removed a live worm from her brain? Did you see that? Was that not weird? They took the worm out of her brain, put it into a cup, and it was still alive. It was still wiggling. And they think, and I bring this up because of infections and things that happen. They think that maybe because of where she lived, she got it from eating vegetables that had fecal matter from a python that was indigenous to that. Now, even vegetables are not safe to eat. Okay, but anyway. So again, kind of keep that in mind as far as plasma loss for your patient from capillary bleeding. Go ahead.
So could you potentially though get life-threatening bleeding from capillaries if, say, it's a 80-something on blood thinners and it's a head capillary bleeding?
Yeah, obviously it increases with age, and it also increases anytime that you've got somebody that is taking some type of a blood thinner. And that also would also always be a concern with an older patient. Yeah. So the other thing to keep in mind, especially if you've got a patient that's laid their bike down, is you may have debris, gravel, glass, vegetation embedded within the wound itself. Even though many times this type of bleeding is stopped prior to your arrival, don't try to remove whatever is in it. Think of it as kind of like a small impaled object, and that way you are able to just kind of dress it and keep it in play there. Venous bleeding is literally just what it says. It comes from the vein. It's low pressure bleeding from a laceration. Now, here's the thing to keep in mind. Even though it is low pressure, which means it does not pulsate like an artery would, the fact that it is steady bleeding can indeed cause it to become life-threatening for your patient. Now, with venous bleeding, most of the time it's going to be pretty easy to stop, okay? Just simply because, again, low pressure, low volume, and it responds really, really well to direct pressure. I've never, ever had a patient of where they've had venous bleeding that I had to use a tourniquet, okay? And so most of the time, just direct pressure on that is going to be helpful. Well, let me come back to that. Arterial bleeding, something entirely different, okay? High pressure, especially your larger arteries that are taken into play there. Now, again, because it is higher pressure, you're going to have a considerable amount of blood, but that's going to be offset as opposed to like venous bleeding of where it's going to bleed steady. You're going to get that spurt with each beat of the pulse. Now, this is where you as a professional and acting and looking and sounding like a professional goes beyond public relations and actually begins to start controlling bleeding. So if you come on the scene and you are there and you're looking at your patient, okay? So let's say Jonah comes on the scene. He looks professional. He's showing compassion. He's using the patient's name. What's going to happen to that patient's mental state?
It's going to calm down.
What's going to happen to his sympathetic nervous system?
It's going to decrease.
What's going to happen to his bleeding?
Decrease.
You're exactly right. It's going to decrease. And so this is a situation where I stress to you, okay? You don't have to be perfect all the time, but you do just have to show people that you care. So you show up on the scene. Joe comes to my house. I've cut my radial artery. It's pumping out blood like crazy. He comes in, says, "Hey, Dr. Young, we're going to take good care of you. We're going to start putting pressure on here." And all of a sudden, it's kind of like, okay, he's got it under control. He knows what he's doing. I can relax. So sympathetic nervous system slows down. Adrenaline secretion slows down. That means it begins to help the arteries dilate a little bit, so the pressure drops in the artery. Guess what? Heart rate slows down, so that spurting that's going like this now becomes more like this. And you may indeed be able to simply control that with direct pressure, okay? Now, if direct pressure does not work, you must, one of the few must, and always, you must go directly to a tourniquet. We'll talk about application of a tourniquet later. But in the past, what we have done in EMS is that we put direct pressure, we've raised it up, we've used pressure point, and then we went to a tourniquet. When I sat in your seat many decades ago, it's kind of like, if you put a tourniquet on, you're saying you're going to have the patient lose the extremity. Not true. Not true. The Army has proven that for us, okay? And so if you need a tourniquet, put it on. Allie.
What are the color differences between each?
Good. Arterial is bright red. It's oxygenated. Remember, when oxygen links up with hemoglobin, it's kind of like you got a red glow stick. And so when it links up with the hemoglobin, it's like the body kind of breaks that glow stick, and it's a really bright red color, okay? Kind of like the color of that backboard back there, okay? When it is venous, it is dark maroon, kind of like Claire's shirt. By the way, love Batman, all right? He's my favorite superhero, all right? So because the oxygen has now left the hemoglobin, and it is deactivating the iron that's in it, so that iron no longer glows. What do you think capillary bleeding would look like?
Right. Clear.
All right, I heard clear, and I heard bright red. Why clear?
It's just the capillaries. It's not like there's not oxygenated blood leaving your body.
What is the clear fluid that you're seeing?
Like blood cells.
Plasma. That's plasma. That's another reason why if you get a massive road rash, your patient can become hypovolemic. Because remember, plasma is the fluid that moves all the components of the blood through. Now, having said that, you can see some bright red in it because remember, within capillaries, what is the purpose of capillaries? Gas exchange. What kind of cells are involved in gas exchange?
Blood cells.
Say it again.
Blood cells.
Mm-hmm. What color are those blood cells?
Red.
Bright red or dark red?
Well, it depends on which stage of gas exchange they're at.
Excellent. The right answer is either it depends or yes. Okay? So if you've got a lot of red blood cells that are coming through in that area that are low in oxygen, they're going to be dark. Okay. If you have a lot of cells that are traveling through that are high in oxygen, they're going to be bright. But again, the majority of the fluid that you're going to see, just like Austin says, is going to be that plasma that comes into play. Very, very good.
Is it possible for like a venous bleed or even an arterial for the person to put direct pressure themselves and then for it to stop? And then you get a call for a different, like there's a different nature of the call, and then it acts up then since their heart rate's going again?
So what you're saying is that I have an accident, I control the bleeding, there's no EMS on the scene,
Yeah.
but later on something
They
happens.
fall off a ladder or
Oh.
something and their heart rate's
Oh yeah,
back
well,
up.
and they wouldn't even have to have additional trauma. So keep in mind that we have clot beds that form that clot off, and we'll talk when we get into shock and bleeding. We'll get into that a little bit more. So that anything can dislodge those clots. The patient goes through and has a history of hypertension. He doesn't take his medicine, and his blood pressure shoots up. It's going to pop those clots out, and they can start bleeding again. Okay, good. So what do? First of all, we want to stop major bleeding. Stop major bleeding as soon as you possibly can. That's a prime directive for you. The way that we do that is we go with direct pressure. If direct pressure does not work, then we immediately go into a tourniquet. Now keep in mind, you don't have to have anything to apply direct pressure. Okay, taking your hand and putting it on a wound, although I would not advise you to do that on someone I don't know. I would tell you it'd be okay to do that on a family member that you really, really like. If you don't like them, we'll see. But again, bare hand, gloved hand on the wound itself with no dressing, no gauze, no bandages is the first stop, the first place that you want to go. So you roll up on the scene there, Mark. Guy standing there, got lots of blood coming out, and he's got his hand on it. You ask him to move it, poof, poof, poof. Take your hand and put pressure on it, and then have your partner get you some gauze pads to apply pressure. If it does not stop or dramatically slow down in 60 seconds or less, your next phase is going to be go straight to a tourniquet. Okay, sir?
Why aren't we going for a tourniquet right off the bat?
Why aren't we? Because when we are treating patients, we always want to start with the simplest and work up to the more complex. Tourniquets do have some side effects. Okay, they can cause nerve damage, especially in older patients. They can lead to some tissue loss, again, in some older patients. A tourniquet is much like, in cardiology, you'll learn about my favorite drug, adenosine. It does all kinds of weird things. But it does have some really, really uncomfortable side effects. And so that's why we start with the simpler things and work our way up. For bleeding, basically what we're looking at here is we've got direct pressure and then go straight into a tourniquet if it doesn't do that. Now, when you get bleeding control, put a dressing over that and splint the area if it's an extremity. Why would I say that? There's no fracture. It's a laceration.
If they're bending and moving the arm, they could either hit it or they could also just from contraction of muscles break the clot open.
Yeah. So we don't want to disturb that clot bed, okay? We worked hard to get it to stop, okay? And especially if we had to go with a tourniquet, all right? So we want to dress that wound, splint it so that they'll hold it in one place and they won't move it, okay? Josh.
What methods do you recommend to splint it? Like, are you talking about like Sam splint or just like?
Sam splint, I love Sam splint. So that would be perfect, okay? Anytime you're splinting an extremity, always be aware that you don't want to splint it too tight, okay? Again, we don't want to reduce circulation because of the splint. You're thinking, oh, I got a tourniquet on here, Bill. What's going on here? Remember, the tourniquet only stops circulation from here down. We'd like the circulation to come up here as well. Yep.
Whenever you put the tourniquet on, if you have like a gauze or something on top of the cut, would you leave the gauze there until you have the tourniquet, or would you just leave it there all the way to the hospital?
Well, here's the thing: if you use a tourniquet and you get the bleeding to stop, you're still going to need to put gauze and a bandage dressing around that, because that will also help to hold that clot bed in place. If you look into the wound and you can see, sometimes, remember we talked about degloving injuries earlier today in cardiology? So sometimes you can actually see the artery or the vein that is causing the problem. Then you go to fingertip pressure. You take your finger and you go in and you put pressure on that artery and you press hard, okay? In many situations, if you hold that long enough, you will stop bleeding better than if you use the tourniquet. Why? Because you have focused pressure now in on that particular area, and it will help in the aid of clot formation. Okay, so now keep in mind again, when there is a laceration, if it is a really clean laceration, let's say somebody gets into a fight and they get cut with a razor, you may get there and you can see the arm laid open dramatically. You can, oh man, there's artery, there's a vein. I can see muscles down in there. Ooh, the white stuff, that's a bone. But you see little to no bleeding. Again, that's because arteries will have a tendency to spasm and close up in order to stop the bleeding as far as when it's going on. Now, when the lining of the vessel, the artery, is disturbed, as you would have from a jagged type of wound or from a tearing type of wound, the collagen is connective tissue within the artery itself, is exposed to platelets that are circulating around in the blood. Now remember, platelets are what stick together to form a clot. And when you have several clots begin to stick to each other, now what happens is you have a clot bed. Around that clot bed, and I haven't forgotten you, if you look, the next time you get an injury on your arm, about 24 hours afterwards, look at it really closely, get your magnifying glass if you need to, you'll see little strands of things going all different ways across that scab that is beginning to form. That's fibrin. What is the purpose of fibrin? It's a net to help to hold the clot in place so it doesn't dislodge and start the bleeding again. Okay? It goes without saying, once you put the dressing on, don't take it off. Why? You disturb the clot bed and the patient starts bleeding again. Resist the temptation to take and look and see how they're doing. Watch for soaking of blood going through the clot. By picking it up and looking at it for whatever reason, it's simply going to disturb the clot bed. Richard.
Two things. One, with the direct pressure on the artery, I don't even know if this would be possible. I'm assuming, though, we can't do something like using forceps to clamp it closed.
I think that would probably be beyond your scope of practice. Again, primarily because surgeons do that all the time.
Mm-hmm.
And they'll also go in and they'll cauterize arteries. Okay, much like I think you were talking about with that piece of metal slag that would fall through. However, if you are in a disaster situation and you got bunches of patients here, you could probably make an argument for, I clamped it off because I had a patient over here that had snoring respirations. And so it's kind of like, let him die or let him die. Why don't I just clamp this off and have somebody hold this in place while I go over and take care of the airway? So,
but in a normal situation, no.
Normal situation, I would tell you no. Okay.
Also, with most of these, after you put the tourniquet on and you're considering putting gauze over the wound, would you wet it first with
No.
with sterile saline?
No, because wet gauze, first of all, does not absorb blood as well.
Okay.
And the second thing is any type of moisture on there is going to thin out some of that fibrin and make it less able to hold the clot bed in place.
Okay. Wasn't sure if that would be something you consider to prevent the gauze from sticking to the clot.
We don't care.
Okay.
Once the clot has been made, if a surgeon has to go in and repair it, then that's a surgeon's problem.
That's their problem. Okay.
So when we're looking at this again, keep in mind that bleeding has a negative impact on our patient's oxygenation. Be thinking about that. If our patient is bleeding, what is happening to oxygen delivery, glucose delivery, and waste removal? So first of all, what is happening to oxygen delivery? And be prepared to tell me why.
It's reduced
Why?
because you don't have as much hemoglobin being delivered to your cells.
Yeah, so all of this blood that is contained within my body right now is doing a fairly decent job of delivering oxygen to all the cells in my body. If I lose half of my blood out here onto the ground, I've lost half of those delivery vehicles to deliver oxygen. Good. What about glucose? Ellie? Same thing. Okay. So instead of now having enough red blood cells to deliver glucose, now half are laying out here, which means our patient could potentially become hypoglycemic. Again, one of the things that I would encourage you to do on your trauma patients is check a blood sugar. Check a blood sugar, especially on your unstable trauma patients. What about waste products?
Increases
And what's the end result?
acidosis,
And how do we determine that?
entitled,
Entitled. Yep. So as we've got our patient on entitled, again, here's the thing to remember about entitled. Anytime that you're concerned about gas exchange taking place, even if your patient is breathing fine, put them on entitled. Okay, so in trauma, you got a bleeding patient. My patient's not having any trouble breathing. I got a 98 SpO2. Everything looks good. Maybe not. Put them on entitled. That CO2 begins to go up. That tells you that our patient is becoming more acidotic from some reason. We don't know yet as to whether it's a respiratory component or a metabolic component, but most of the time in trauma, it's going to be because of a respiratory component. Why? Because the body can't get rid of the CO2 and lactic acid. So they're becoming more and more acidotic as far as they're going around there, right? Now, we talked about tourniquets, but again, review the steps in your textbook. Did you guys get a PHTLS textbook for this class?
Mm-hmm.
Okay. I think it's like on 172, 175, somewhere in that area that you can go in and it kind of gives you some graphics. We'll do a little bit of work in here. Look for your airway. Assess the airway for patency. Do you hear any sounds? Breath sounds should be essentially noiseless and easy going in and out. What are some breath sounds that we might hear that would indicate an upper airway obstruction?
Snore.
Why stridor? What give me an etiology or a cause from a traumatic perspective that would lead to stridor?
Stridor happens from when your upper airway is like closed off somewhat.
Yep. So
Choking.
what might, from a traumatic perspective, cause that upper airway to begin to close off?
Car crashes.
More specific. Yusuf?
burns, or trauma to the throat.
Yeah, so we can get burns or indirect trauma to the throat. Okay, burns because of the superheated air causes that to begin to swell up. Indirect trauma to the throat, same principle. Now that area right there at the glottic opening begins to swell and narrow. And so we begin to hear that high pitched sound. Claire.
Just curious, could chemical hazards be the same?
Yep, same thing. So you can have radiation burns, you can have chemical burns, or you can have thermal burns. The end result is it's a burn. And anytime you have a burn, you're going to have edema. What would be an indication of gurgling? We talked about that in 310 today. What would cause gurgling? Blood, emesis, any kind of liquid. Treatment is going to be suctioning. What can we do really, really quickly that's very simple for stridor if we suspect it's from any kind of swelling at the glottic opening?
Open their airway.
We can open it. We don't want to look, and especially when we talk next semester about pediatrics and epiglottitis, we don't want to go in there and upset the kid. But what could we do? A BLS procedure that would help to lower that swelling. Claire, Yusuf? You're on the right track, not a nebulizer. Allie?
I was going to say cool air.
Tell me more. What kind of cool air?
Outside, fresh
Okay.
cool air.
So now, if it's cool, it's typically going to be dry. And what we would really like is cool, humidified air. Where could we find cool, humidified air on the ambulance, John?
Humidifier.
Your humidifier. Perfect. Yeah. So put your patient on humidified air. If you need to cool it down even more, take your cold pack, activate it, take your oxygen tubing and make a still out of it. Wrap it around the cold pack and then either put a towel over it or put some tape around it to hold it in place. And that will help to cool it down a little more, not a huge amount. Richard.
We don't have a humidifier. No, how do we do that?
If I'm not mistaken, you are in violation of Kentucky law because I believe all ambulances are supposed to carry humidified oxygen, especially for long distance transfers. I'll have to check. It's been a long time since I've had to worry about that, but I'll double check on that and find out. But you should be carrying humidified oxygen for your burns.
You're correct.
Oh.
We just talked in ambulance.
Okay.
Have to have it on there.
Okay. All right. So yeah, humidified oxygen is going to be used more so for burns than you would, but if you got a patient, so for example, I used to work out in Kansas, okay? A little town called Garden City, which was an hour from Dodge City. Garden City was not the middle of nowhere, but you could see it from there, okay? And I did critical care ground transports. And literally, we either went to Colorado Springs, which was 4.5 hours away. Most of ours went to Wichita, which was 4 hours away. You don't want to be on dried oxygen for 4 hours by nasal cannula. Your nasal passages are going to be bleeding by the time you get to the facility. So that's why humidified oxygen is the best.
If for whatever reason the like let's say you're at a backyard barbecue or something and someone burned their throat, and in the time between that and getting the ambulance humidifier, could you have them breathe cold air from a cooler that had a lot of ice in it, or was that too cold?
No, I don't think it would be too cold. I think it would be, your biggest concern would be, again, the cold air coming from an ice box is probably going to be more dry. So,
in the absence of a humidified cannula, could you just nebulize their water?
Yep, you sure could. You sure could. Okay, and again, what you wanted to be done is what's that, Austin?
That's the only way I've ever seen.
Yeah.
Done on the ambulance.
Yeah, so that would be the way that you could do it if you don't have a humidifier. You may need to intubate your patient. Understand that in these situations with upper airway obstruction, primarily from burns, you may have to go with a tube that is 1 to 3 sizes smaller than what you would normally use. which would require you to modify what when you're ventilating the patient? Nope. Tidal volume. Well, tidal volume is going to be less, so you're automatically going to to modify that. How do you compensate for a decreased tidal volume? PEEP wouldn't be a bad idea, but that's not going to offset your reduced tidal volume rate. Okay, so we're going to increase the rate, all right, to get the same amount of oxygen over the course of a minute in there. Again, keep in mind if you've got patients that have lacerations to the throat, you're going to have lots of swelling. You're going to have lots of blood in there. This is where you're going to have to suction your patient. You may have to leave the C-collar off of your patient. If you have a two-part C-collar, leaving the back part on will help to hold the patient in place. The other thing you want to do is to, if you're concerned about spine injury, have someone hold the head in place, which makes it more difficult. And then we have wonderful issues of kyphosis. What is kyphosis? Yeah. So, yeah. So I have a bit of kyphosis. I hope it doesn't get worse as I get older, but sometimes you will see these older people that are literally hunched over like this. I can remember seeing one poor gentleman that when he was walking, he was looking at the ground because he couldn't raise up. Whatever you do, don't force these people to go flat because you can once, and then you've caused severe spinal column damage as well as muscle damage because those muscles become really, really atrophied. So again, you have to build up that area that is open in there by raising the head of the stretcher up, patting the void with pillows and intubating in that direction. Okay. Now, one of the things you want to do is once we've got airway done, now we're going to go on to our breathing. Look at the patient for an adequate chest rise and fall. I want you to do something, but please don't be creepy about it. Watch other people breathe. Okay? Don't sit over in the cafeteria and go, what are you doing? Watching you breathe. Okay. Probably going to get a phone call if you do that. But try, be in an area and just kind of look around and watch people breathe. Look at people of different sizes as to how much or how little their chest wall expands. That's one of the ways, and even more so when you've got your patients, okay? That's one of the ways that you can look at determining what is going to be normal. Look, because when a patient's breathing, it should, like I said, relatively be noiseless. Sometimes that changes because if they have some type of like a deviated septum, they may make noise that is completely normal for them. Listen to your breath sounds, especially in cardiology, as well as in here, we're going to focus in on different breath sounds, okay? Because breath sounds tell a story. Breath sounds tell a story. Can tell us whether a patient is in congestive heart failure, whether they have pneumonia, or potentially whether they have attention pneumo. So we want to listen. Let's begin now. If you're working EMS right now, listen to all of your patients' breath sounds, even if you're transporting a patient from home back to the nursing home. Okay, listen to everyone's breath sounds. Keep your O2 sat above, it says 95, but 94 or higher is perfectly fine. Okay, don't worry about it. If it's not up there at 100, it's really not going to be any kind of a problem. And then again, if your patient has facial or head trauma, be ready to use suction in a lot of it for a couple reasons. Number one, if you have head trauma or facial trauma, and many times you'll have a combination of both, what will happen is your patient will bleed profusely, and then with a head trauma, Kira, your patients will often begin to vomit a lot. Okay, so use salad technique, as we're learning here, to how to continuously suction that airway and to keep it open as far as when we're going there. Use capnography, okay, especially in trauma and particularly in head injuries. Now, why would I tell you to use capnography, especially in head injuries?
Because with the lack of oxygen, the head can show like altered mental status. So like using capnography would help see how much like CO2.
So it's going to tell us about CO2. It's not going to tell us anything about oxygen. So you're on the right track. Somebody help flesh out what she just said. So CO2 is incredibly important in head injuries. Why do we need to particularly use end tidal on our head injuries?
Respiratory acidosis.
Tell me more.
So your end tidal is higher. You're retaining the CO2 because you're not exhaling, expelling the CO2.
Which means you should then do what?
Potentially hyperventilate your patient.
Controlled hyperventilation. So in head injuries, and we'll have an entire unit on head injuries, let your end tidal drive both your tidal volume for your patient as well as the rate at which you ventilate your patient, okay? So as your capnography, as your CO2 goes up, we want to get rid of some of that CO2. So increase your rate and your volume. As the CO2 begins to drop, and if it begins to drop down less than normal, slow down your rate, decrease your tidal volume. We'll talk more in head injuries as to why that CO2 is so very, very important as far as when we're looking at that. Right? Now, Mark.
Sorry, I don't think I heard you. Why is it especially important for head injuries specifically as opposed to any other kind of injury?
For head injury in particular, I'm not going to go into a whole lot of detail, but increase or decrease of CO2 has a direct impact on the amount of intracranial pressure that's going on. And again, we'll get into that considerably in head trauma, but that's one of the reasons that you do that. We used to think, again, back in the dark ages, remember I told you that about 25% of what I'm telling you now, if you do it in 10 years, you'll go to jail for it. Well, back in the dark ages when I went through paramedic school, we used to hyperventilate our head injury patients at like 30 and 40 breaths a minute. And we would get them in with incredibly high PO2s, and they were all dead. Why? Because we were blowing off the CO2, which meant their brain wasn't getting any blood, okay? You do that now, your next statement is going to be, would you like fries with that? Because you will lose your license, okay? Because that's a well-known premise as far as when you're doing that. The last thing we're going to do is we're going to look at circulation, okay? So assessing the patient's circulation involves more than just checking the pulse, okay? When you're checking the pulse, the three things you're looking for is rate, too fast, too slow, or just right, rhythm, regular, irregular, or regularly irregular, and quality. Weak, normal, strong, or bounding, okay? And in trauma, especially within your head injury patients, that bounding pulse, kaboom, 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 is probably an indicator that they've got really high blood pressure, which means you've got increased intracranial pressure that's going on. Again, within circulation, look at your patient's skin. As we said earlier this morning, and this is true for trauma, for medical, for pediatrics, for OB patients, always, always, always assess your patient's skin. Gives you a ton of information, some of it really, really early as to the shock status of your patient and as to what's going on with them. Okay. Now, when we're looking at this, here's the thing to keep in mind. We used to say, well, if I got a radial pulse, I've got a systolic blood pressure of what?
At least 80 or 90.
At least 80 or 90. The latest research says, maybe not so much. Okay. So again, this is one of those situations where you would assess your entire patient. And in circulation, we would assess the pulse, rate, rhythm, and quality. We'd look at the patient's skin. We would determine their level of consciousness. Do they have an altered mental status? And then, obviously, if we can't get a blood pressure for whatever reason, now that kind of gives us a little more area to go through. All right. Now, here's the other thing: is keep in mind that when patients go into John, go ahead.
So now the non-systolic radio pulse is garbage?
I'm not ready to call it garbage,
Okay.
but you won't see any questions about it on your exams in here, just simply because the latest research says we don't think that it is as accurate as what we thought before. So again, there are other ways that we can get that information. If that was the only way of determining circulation, then I would say, okay, we got to make a decision one way or the other, but we really don't.
If you feel like the radial pulse is too weak, or you feel like something's off with it, would you go for a carotid pulse, or would you not want to?
So here's the thing: when you're assessing a pulse, if your patient is conscious, the first pulse you should assess should always be the radial. Okay. If I'm going towards your head and you're not expecting it, that's going to cause an artificial increase in the heart rate, which may lead you to think that our patient could potentially be in compensated shock. If you're not getting a good enough pulse here, ask the patient, hey, I need to check the pulse in your neck. Is that okay if I do that? So again, anytime you want to do that for a conscious patient, then you should ask. For unconscious patients, I would assess both your radial and your carotid at the same time and compare them. The patient's not unconscious; they're not going to know exactly what's going on. Keep in mind that when a patient goes into shock, one of the very first things that happens is the heart rate goes up. Except in what group? Say again?
Pediatric.
Nope. Pediatrics will also go up. But we'll eliminate pediatrics and say these are only adults. What group of adults will often not be in shock and yet still have a heart rate of 60 to 80? Say it again. Okay, I'll give you that one. Okay, so athletes, yes. Okay, so they normally have a very low heart rate, so it may go up. I'm talking about people like me that are not athletes, obviously.
Geriatric.
You're closer. Why geriatrics?
Because they're on different medications.
What kind of medication? Specifically, one kind of medication.
Beta blockers.
Beta blockers. Understand. And this is why it's so important to understand pharmacology, okay? You take a beta blocker is kind of like a governor on an ambulance. You can drive your governor, and most of the time they're set out at about 80. You can push that gas pedal or that diesel pedal as much as you want, but it's not going to go above what that governor has it set as. Beta blockers are very similar. Beta blockers are designed to keep the heart regular, but to also control the heart rate. We'll talk about this when we begin talking about shock, about what kind of problems this can bring about. Because remember, an increased heart rate is part of the body's response to shock to compensate for what's going on. So again, if you got a patient that's on a beta blocker, expect their pulse and their blood pressure to be low. Okay? Anytime you've got a patient, as far as circulation goes, that's got a head injury, because typically in a head injury, we would expect the blood pressure to do what? Go up and keep going. If you got a patient with a head injury and you got a blood pressure of 70 over 40, what's probably happening? Maybe, but not that soon.
Is it herniation?
Maybe, but that herniation would be a normal blood pressure. So if you got a patient that is hypotensive and they've got an obvious head injury, look for bleeding in here. Okay? Now they may be bleeding outside, But again, many times, Josh, it's out of sight, out of mind. And so look for your patient for the possibility that they've got internal bleeding that's going on. In particular, and this is all just kind of, and we'll talk about each one of these, but if you've got a patient that's got a pelvic fracture, your patient can bleed to death. Remember, the pelvis is designed something kind of like this. Weakest spots are in the back and in the front. It's rare that you will have enough force in the back to cause a direct fracture. But when the pelvis breaks, it usually will break in these two spots right here, and it will almost always break in both of them, and then the pelvis does this, okay? I encourage you to go to Google and look up an x-ray for an open book pelvic fracture. It looks nasty, okay? And in addition to that, your patient, all of the blood in your body can be contained within your pelvis. And it's very vascular. And so you can indeed bleed to death from a pelvic fracture. We'll talk more about how to deal with that when we get into orthopedic emergencies. Again, when the blood begins to be shot away, the skin becomes pale, cool, and diaphoretic. Okay? In shock caused by loss of blood, it's unlikely that your patient will become cyanotic. Why?
What was the question?
I'm sorry.
It's okay. That's all right. In a patient that is in shock from trauma, it's unlikely that the patient will become cyanotic. Why?
Either lack of circulation or lack of blood volume.
Okay, the latter is the right answer. So you can still have circulation, but a lack of blood volume. There's not enough blood volume to turn dark purple to reflect that cyanosis. John? Okay, good. And remember, we get sweaty because of sympathetic stimulation that comes along. So make sure that you are, if the patient is sweating, make sure that they're sweating for an appropriate reason. A few weeks ago, if they were outside sweating, you could say it's because it's hot. Okay? If it's 20 degrees outside and they're in a car and they're sweating, something else is going on. Going to stop there, guys. Very good job. Continue to do your reading. Watch the video because it contains the rest of this lecture. I love the way that you're discussing. I should be able to bump everybody's scores up, I think, by Friday for your exam. Still got one or two people that will need to take it, and we'll go from there. Yes, ma'am. Any trauma. That the one that I gave you is an example, but it can be any trauma.
So we can use our own example from.
You can do what?
We can use an example from polypod or whatever.
Oh, absolutely.
Do we have to turn them in online or can we fill them out on paper?
You have to fill them out. You can type it in. I wanted into that. That's why it's online. It's a fillable Word document. And then I want you to email them back. Please make sure you use the format that I've got because I've got my computer set up to sort and to put your stuff into a special folder. If it's not exactly like that, I'm not sure where it'll go. Guys, if you need something, all you got to do is ask. Just let me know.